Ever since that incident, they took chain and they chained all the chairs so you can't throw the chairs anymore.
Nice. So he is our difficult airway extraordinaire, and he's also really good at cardiac too. But yeah, he's the one that takes care of Troy for us. So
Soon to be picked one.
soon to be Pickwa. Yep.
Cool. Y'all know Dr. Brady.
Hey, Doc.
You guys know Anna? She's your EMS coordinator at Southeast for the time.
For a time.
I'll be taking her over.
And now-
Southeast,
and now
so
you
if
know,
there's any
John.
problems, please let me know.
All right, so we'll get started. Talk about difficult airway today. Obviously, it's one of the most common and most important life-saving skills that we do in our profession as EMS providers. We're going to have hopefully a fun day though. We're going to have some pick trachs, so we're going to do some surgical Christ, we'll go over surgical Christ, as well as some PEEP demonstration as well. We're going to have a two-person technique in the station, and then we're going to have a vomit station. So we have a vomit head that we developed, so we can put some fluid in the airway and make you suction it out and try to intubate. So that'll be pretty good hands-on instead of listening to me lecture. So we're going to go over some interventions, maybe some different techniques to deal with the difficult airway. Also, we'll talk about adjuncts, so your secondary devices, and when to use and when not to use surgical Christ as well. Difficult airway, obviously the guy on the left is going to be a difficult airway. We got some kind of impalement there. So that could be a difficult airway. Body habitus could be a difficult airway, you know. And then there's also the difficult airway because we're nervous, or we're in a stressful situation. So that has performance anxiety involved in it as well. That makes for an airway to be difficult, okay? So, you know, the only thing you can do for that is just practice, practice, practice. If you get the chance to participate in cadaver labs, I highly recommend that. I don't know if you guys have ever participated in any of those before, but those are really good. New medics, you guys all medics? Wow. So, you know, if you get the opportunity to go to OR even and do some innovations, it's the best. Most of the guys medics here,
Yeah, we're all medics.
high percentage, or all of them.
Yeah,
So-
there's only a few that are EMTs, but all of our full-times are medics.
So the problem with that is then you have a high volume of medics, and you only have so many innovations, right? So it's trying to rotate that to get everybody proficient at it.
Right.
So that's difficult to do. Now you have mannequins, you know, you can practice on, even though that's not real life, you know that. So you can be really good at a mannequin, but then difficult in an actual patient scenario. So, but at least get your steps down, so you know what you're going to do step by step at least, and have it back up as well. So, but you know, you get nervous, your heart rate goes up. You know, at about 115, you start to lose fine motor skills. 150, you start to lose gross motor skills. Obviously, we need those motor skills when we're innovating, we're talking about drugs, things like that. So, just try to relax. This guy fails automatically because where's his laryngoscope at? Which hand is the laryngoscope at?
Yeah, it needs to be in his left.
It's in his right, so he failed already.
Yeah.
So, just briefly about A&P, obviously the nasal airway versus the oral airway. Nasal is pretty much open. There's a lot of space there. There's not a lot of stuff in the way. So don't forget about your nasal airways, your NPAs, and, versus your OPAs. And then you look at the oral pharynx, and that tongue is just so huge, right? And that's our enemy when it comes to innovating, right? We have two enemies when we talk about innovating. One is your tongue, and two is fluid. Okay, those are two big enemies of us for us for innovating. So, and then your tongue's already big. So then when you get trauma, what happens is it swells. What happens is the anaphylaxis. It swells, right? So that even makes it more difficult. All right? So don't forget your nasals. You guys nasal innovate very much?
Yeah.
You guys don't RSI, correct?
Do not RSI.
Do not. So nasal is kind of a good secondary, right?
Yeah.
So over in Indiana, where the area where we run, we have a pretty aggressive medical director, and we do a lot of, we've been doing RSI for a long time. So with RSI and with the availability of CPAP and a lot of us carry BiPAP now in the field too over there. That really has diminished the use of nasals. So, not to say it's not a good tool in our toolbox, we just don't use it as much.
Yeah.
So, but just remember, yeah, you can't RSI, but you can definitely nasal if you need that opportunity to do it. Or unconscious and need an airway. So, epiglottis there, that's our big key that we're looking for when we do innovation. We'll talk about that here in the next slide. So, the bottom left, wouldn't we all like to see that when we go to innovate, right?
Right.
How often do we see that?
Great.
Never.
It's pretty easy with the King Vision.
Yeah, King Vision does make it nice. However, what's in our way usually when we let it go? Secretions maybe, vomit, blood, things like that get in our way. Macaroni, hamburger,
Right.
the nasty stuff. So then we have to try not to dry heave ourselves from it. You stick the yank hour in there and it gets stuck. And you just have to keep pulling it out, and getting all the stuff off of it. So we don't very often see that, the nice glottic opening. Epiglottis though here again, that doesn't show up very good. Should get my money back. It said the green was supposed to show up on the screen. So.
It's probably screwing me because it's TV.
Anybody heard of Dr. Rich Levitan? He's like one of the nation's gurus on Airway. And he believes in what they call that's epiglottiscopy versus laryngoscopy. So you actually see the epiglottis first, and then once you see the epiglottis, then you go for the laryngoscopy. So that's kind of the way he teaches. And I definitely go by that. So what our landmark we're looking for is the epiglottis. And once we see the epiglottis, we know where the vocal cords are. Okay? So it's just like a comparison to a golf course, and you have the flag. Once you know where the flag's at, you know where the hole's at, right? Do you have to see the hole? No, because you know where it's at. So the same way with the epiglottis. If you just kind of creep down the tongue, you find the epiglottis, you know exactly where the vocal cord, the glottic opening is going to be. So, because sometimes down here on the bottom right, when you stick it in there, you don't always see. You're not going to see those vocal cords every single time you see.
What's up, man?
How's it going?
Good, man. How you doing?
Down here, huh?
I'm everywhere.
You're everywhere. Right? So just keep that in mind. If we can find the epiglottis, it's going to be very helpful in where we're looking for the larynx. Okay. Ventilation, perfusion. Don't forget, perfusion is a key factor in this. When we talk about O2 sats, we talk about end-tidal capnography. You do have to have blood flow to the alveoli to get that gas exchange. Okay, and so what I mean by that is you got a patient who's intubated, you're bagging the patient, and you just can't get their O2 sats up or their capnography up. They get really bad numbers. And you're like, man, I know I'm in. And then you hit the recycle button on the blood pressure, and you get a blood pressure of like 58. So are you really going to get good gas exchange there with a low blood pressure like that? So no. So sometimes it is a perfusion problem. It's not always a ventilation problem. Okay? And then sometimes it is a ventilation problem. Sometimes, you got your end-tidal CO2 and it's reading low, and you just can't get your end-tidal to come up, and then you look at the guy who's bagging the patient, and they're bagging about 30 or 40 times a minute. Right? Because what I said, your heart rate's going to go up. It's a stressful situation. He's not paying attention. So now you slow that respirations down and his end-tidal comes up. Don't be so quick to pull the tube, kind of go through your things and say, hey, are we breathing too fast? Is the tube in place? Okay, just don't yank it out. Assessment of respirations. We're really good at measuring the objective things. Why? Because they print out a number on our screen, right? So we're really good at documenting that, but sometimes we fail to document good what's the quality of their respirations, okay? Or what's their mental status, okay? So if you can rule out that your patient doesn't have an altered mental status because of drugs or because of trauma, then one big key thing is this, they might be hypoxic, okay? So because altered mental status is an early sign of hypoxia. Okay? So keep that in mind. And always document that on your record. Interesting fact, just because we can tube somebody doesn't always make it better. Okay? So if you look at the survival rates, BVM versus innovation and respiratory rest. Okay, so good quality BVM actually out-survives innovation. And why is that maybe?
PVM's over the mouth, innovation's more invasive.
It is more invasive, so maybe we take too much time to do it, and we let them become hypoxic, more hypoxic in that process, and then we do more harm than good. Okay, CPR is about the same. Okay, so you guys probably have a lot of hands on. You got a code or something like that. You probably get how many? 5 at least on scene. So you got a lot of hands. Some places we only have 2 or 3 people.
Yeah.
You know, they're a little bit behind the 8 ball sometimes with getting things done. So at least you guys have a Lucas device.
Yeah.
That makes it nice too.
Mhm.
So that frees up somebody from doing that, other than you got to get it hooked up,
Right.
right? So you got to prioritize. And some of those rural departments always say, "Hey, I've never seen anybody survive or wake up just because you meditate." So always go by your steps. Get your CPR going. Get your ID established. You know, and if you got plenty of personnel, then you can take care of your innovation. Okay. Just don't let it hinder and hold up CPR. Again, you guys got the Lucas device, so that takes care of that issue. So, back to the basics. I know it's kind of boring with the basics because we're just talking about VVM patient, right? That's not very glorious as compared to innovation. So one of the big key things is positioning your patient to bag. Okay? How do we always bag a patient usually, typically? Flat or upright? Flat. And I really don't know why we bought into the theory of why we bag somebody just flat. Right? For those who are like slightly overweight, is it very comfortable to lay flat, completely flat? No? What happens usually? You have a little more trouble breathing, right? It's not very comfortable, you get a little lightheaded, right? Because your diaphragm is doing what? And your weight in your stomach is doing what? It's pushing up. So your diaphragm can come all the way up, almost 2/3 of your chest, if you lay somebody completely flat. Okay? Which means you take that 2/3 away from their lung capacity. So that's why they get short of breath. And now we expect to bag these patients that way, right? It's kind of counterintuitive, right? So now they're finding in the ORs and emergency room studies out there, you see this guy over here, the dummy on the screen, or on the cot, elevated 30-degree position with his head tilted parallel with your ceiling of your truck. That is actually the best way to bag a patient. Now obviously if you've got a trauma patient with C-spine precautions, you can't do it that position, but you still can elevate them up. Okay? So that is technically what they're finding out is the best position to bag. Okay? Less resistance. You get better coronary perfusion pressure. Again, that weight comes up, right? Puts pressure into the thoracic cavity. Coronary or arteries don't perfuse. You get more weight on your carotids, and your jugular is returning blood down to the heart. So then you get a backup of blood into your brain, which causes an increase in your cardiac pressure. Okay, I'll show you some studies later on that too as well. OPAs and NPAs, we kind of touched on that a little bit. You guys always drop an NPA when you bag a patient, or do you drop just an OPA? OPA. Don't forget your NPs as well. So, and there's nothing against it that says you can't drop 2 NPs and an OP to try to bag a patient, because then you're opening up everything. That's the best way, the most effective way to bag. Is drop 2 NPs, 1 OP. Okay. Two-handed perch technique is also the best if you have the personnel. Okay, so if you have the personnel to do it, that's the most efficient, because why? Especially if you get the bigger patients, can you really get a good grip on the face? No, so a lot of the air goes what? Goes out, so you lose about 1/3 of your PDM volume that you're actually trying to squeeze in. Okay, so two-person technique, somebody's holding the face in what they call the VE position now instead of the CE. It's kind of V, you kind of put your fingers like that, and then 3 fingers on both sides on the jaw itself and bring it up. Okay. Again, if you're laying this patient flat and you're pushing down, what are you doing? You're also doing what to the chin? You're kind of blocking the air you're trying to get in. Okay. Cricoid pressure, that's kind of going by the wayside. More studies are showing now that it's less effective than what we used to think it was. What did we used to think Celtics movement was good? We used to think it did what?
Chords in the vision.
Well, not for innovation, but just for bagging. You guys ever do it when you're bagging? Yeah, so the theory was we tried to block the esophagus, right? Well, now what they're saying is the esophagus will actually move out of the way, so it's not really effective. So, and can actually cause more vomiting in patients. So, they're finding out that's not the best way to do it. Always have your suction ready. You can see the picture down here on the bottom. Can you see that? They do have that patient elevated in the 30-degree position for bagging a patient. Okay. Talk about BVM. So the average BVM holds about 1,800 cc's of air in it. So I think this is the one we give you guys, right? This is one you guys restock with. This probably has a little less than this. This is probably 16. This is probably an 1,800 cc. So the point of that is most people, as you're sitting here breathing, you're only breathing in 400 to 600 cc of volume, right? And if we squeeze this whole bag in there, what are we doing? We're putting way too much air in there, right? So 3 times, if we get the whole bag in there, which is almost impossible, but if we did, we're getting 3 times as much air as we need to. And again, what's that do to the lungs? Or what's that do to the thoracic cavity? Increases pressure. Again, a lot of it's going to go to the stomach, so what's going to happen? Air goes in the stomach, it's going to come right back at you, right? So, speaking of that, always, you guys have goggles. Always try to wear goggles. They used to make fun of me at the hospital when I would intubate, because I would get the full shield. I don't like puke, and I don't want it on my face. Okay? So, always wear protection. So, I got 2 different bags here. This is what you guys have. Okay? You can buy a PEEP valve with it or get a PEEP valve as well. This is a PEEP device. Does everybody know what PEEP is? We're going to show you, demonstrate what PEEP looks like on the actual pig lungs when we go to do our lab over there, so you can see what PEEP, how effective it is at keeping that alveoli up and open versus not using PEEP. Okay? So this is the one we use over there. Believe it or not, they do make smart BVMs now. This is kind of called what we call a smart BVM. There's a little pull tab in here, and there's a battery in here, but it's already dead. It's already fallen out. But once you get a code or something like that, or rescue breathing, you pull the tab, there's a little red light that pops up there every 6 seconds. So you don't have to count. Okay? Isn't that cool? So you can sit there and breathe for the patient when the light kicks on. This also does have a PEEP device in it with it. However, I've lost that, so I don't have that to replace it. But there does come with a PEEP valve. It comes with a light. And then there's also a pressure switch here. So you can sit there and squeeze like that, or you can turn the pressure on, and it prevents you from over-inflating or rapidly inflating the lungs, if you can hear that. So I'll let you guys pass that around. Those are our options. We do not provide those for you guys, sorry. But they are out there, okay? So this is a PEEP device too, if you guys want to pass that around. Usually we start at 5 and then work our way, increase the PEEP, if you guys want to see that. Now we do have those at the hospital. I think you would have to ask for that specifically though. That's not something we typically restock. Obvious problems with BVM. We're not paying attention, right? Like I said, it's the less glorious thing. So if we're bagging a patient, we might be looking at whatever Tim's doing over there with the IV or whatever, or getting something ready, or things like that. So we're not really paying attention to what we're doing. We're looking at something else going on. So that's a big problem. Obviously, poor mass seal, excess of pressure, hyperventilating. So again, especially you might think, well, let's just put an EMT on it, or put the rookie on bagging the patient, right? But what's the problem there is they're not familiar with a lot of calls. They get really nervous and they get hyped up, and I'm sure you guys all work with people like that. They get, spastic on calls. So what happens, again, their heart rate goes up to 120. What do they start bagging? Yeah. Okay, especially your pediatric calls are worse because everybody gets a little amped up for peds in it. So just be cautious. That's where that bag right there is nice because it does count for you. So those are just the rates. So 6 to 8 seconds. Rescue breathing 10 to 20. Why do we do 20 per minute on end-tidal CO2 for cerebral herniation?
Maintaining the capital minute pressure.
Right. So we're there. We are over ventilating the patient, not putting too much air in there, but just increasing our respirations to do what? Increase oxygen in the blood, right?
Yeah.
So what does that do to the coronary arteries? Constricts them. So there it temporarily decreases intracranial pressure. It's a temporary fix, yes. There's a lot of controversy on allowing us in the field to do that, but I'm a firm believer of that. One example, I had a 10-year-old neighbor of mine, actually. Again, I live rural area, so had a 4-wheeler flip over on her. She had a helmet on, but it was an open face helmet. You guys are. So, had an open face, and the 4-wheeler, the full-size 4-wheeler, just landed right on her face. So obviously with the helmet, it was open face, it crushed her sinuses. And anyways, we ended up RSIing her on scene, waiting for the helicopter, and while we were doing that, we noticed she had unequal pupils. So one was fixed, one was blown. Her blood pressure went up. She became bradycardic. So what is that a sign of? Everybody remember that from school? Cushing's triad. Okay? So she had Cushing's triad, so we knew she had increased intracranial pressure. So we hyperventilated her for like 2 minutes. I've never seen this before. I've never seen it, again. But her actual pupil was in the field, correct? And she walked away out of the hospital a month later with no damage. So that was a good story. It does work, so I'm a firm believer of hyperventilating patients with increased intracranial pressure. Okay. Here's your peds. Obviously, the obesity, bearded patients are going to be difficult with obese. Toothless patients, I'm not sure you guys have any toothless patients down here. Snoring, how do you really know that? Unless you go there and they got their CPAP marks still on their face and maybe those are going to be difficult to bag patients. Oxyhemoglobin dissociation curve. So how do we measure oxygen in the field? We use what? Pulse ox, right? So in the hospital, though, we do what? We do ABGs. We get a blood count. It's more accurate. So the pulse ox is only so accurate. And so what I mean by that is us sitting here normally, we run about 75 to 100, maybe a little over of oxyhemoglobin in our blood. All right, so we should read in that 95 to 98%. All right. Well, if we're overventilating a patient, over-oxygenating a patient for a long period of time, we get a lot of oxygen in the blood that we can't measure. Once we get 100%, we don't know what it is. Right. So as you can see, this curve stops at about 140, but over that, it can keep going on. So sometimes in the hospital, we get readings of what? 200. 300, you've seen those, Dr. Brady, I'm sure. You get really high oxygen count in the blood. That's kind of counterintuitive for us. Why? Because what we talked about, oxygen, increased oxygen in the blood does what to your vessels? Constricts, so then you can cause more ischemia to your vital organs. So that's why, especially if you take PALS, anybody taking PALS lately? Yeah. So they teach PALS on post-cardiac arrest, they want that O2 stat to be 94 to 99. And you say, why are they being so picky about that 99? And this is why. We don't want too much oxygen in the blood causing more ischemia. Okay. So you're not always shooting for that 100%. Okay. Ventilate versus intubate, we have to make that decision. All right, on what we're going to do. So obviously the tearing patients, rapid shallow breathing, use of accessory muscles, change of breath sounds. Decreased mental status again, so if they start to go unconscious, what tool do you guys have? If they're unresponsive, they have a gag reflex, you can do what? If you need an intubator. So what kind of intubation would you guys do? because you don't have RSI, you
It's
do
one of
the nasal. Okay. If you said it, I'm sorry. Yeah. So how do we try to avoid innovation? Because just because we can innovate doesn't mean we should innovate. We want to try other options, okay? So we want to increase our FI2, which we can't really do that in the field. That means your oxygen, percentage of oxygen, because oxygen in your guys' tanks are what? They're 100%. So you can't adjust how much air is coming out of that or how much oxygen versus mixed air. So you guys can't control that. So all you can do is increase the delivery method. So you can go from the nasal canyon, you go to the non-breather, you go to the VDM. Okay. Again, volume, rate, PEEP, so your positive end expiratory pressure. So if you need to use PEEP, and how do we use PEEP in the field, especially if we don't have those? But what tool is basically PEEP? CPAP. So your CPAP is basically PEEP. So when you turn it up, you're increasing PEEP on the patient. What's the difference between CPAP and BiPAP? You guys know? Because a lot of times you guys bring in maybe a CPAP patient, and then what do they usually do right away? They put them on BiPAP, okay? And it's nothing against what you guys are doing, okay? It's just how it's delivered, right? So CPAP is continuous air pressure coming in. So no matter what, whether they're breathing in or they're exhaling, it's a continuous same pressure. BiPAP is bi-manual, or bi-pressure, okay? So we can adjust how much pressure we want to push in when they inhale versus how much pressure is pushing against when they exhale. So that's all that is. We can adjust that, and that's BiPAP. So it's a little, that's why BiPAP is typically better. Okay, does that make sense? Again, some EMS departments, like over where I run, we actually bought a CPAP and a BiPAP machine. So those are a couple grand. But over here, they're not. You guys don't have a machine. So, you just have the disposable line. I did see where they are coming out with a disposable CPAP and BiPAP though device. So that's kind of neat. Not sure how exactly that works or how good it works, but they are coming out with it. So obviously intratracheal intubations are our number one way to secure the airway. So when do we do it? Basically when we decide people can't protect their own airway, right? Whether that be a prolonged seizure patient or a stroke patient or respiratory failure patient that just can't protect their own airway, or trauma patient. Okay, those would be the ones we intubate. Right? Gag reflex, there are some people that don't have gag reflexes, so I would say that's not always a good sign. Hey, they don't have gag reflex, let's intubate the patient. Basically, a better one maybe say is, do you think they can swallow? And if you can swallow, you can basically protect your own airway. Okay. Just because it's like, we don't always want to intubate patients. There are complications. We can cause more damage. Sometimes us firemen are a little rough sometimes, especially when we go to intubate. We shove it in there and we cause more trauma, break teeth, things like that. Tension pneumo we can cause, bradycardia we can cause because we're stimulating the vagus nerve, and we can cause death. Okay, so obviously not something we want to do. Our goal is obviously, I know this is CADA, but we want to pass the tube. We want to do it though without hypoxia and without causing hypotension. Okay, so just because we pass a tube on a patient, does that mean we're successful though? No, because if we cause more hypoxia and we cause more hypotension, then we've done more damage. Okay. Have you guys seen the shock index or heard of the shock index before? No? So basically you take your systolic pressure divided by your heart rate, and if it's less than 0.8, and you go decide, I'm going to intubate this patient, they are highly, or the percentage of those patients going to hypotension or cardiac arrest are extremely high. So if you got a hypotensive patient and you got a patient that's got a heart rate of 160, that's not a good number. Those patients are more likely to get cardiac arrest after you intubate the patient. Okay. Difficult airway, obviously you see these two patients. If you walked in on those, you could obviously say, is that going to be an easy intubation, or would that be maybe a little bit challenging? Even for you gentlemen or girls who think you can intubate anybody in the world, these are definitely gonna be tough, right? So these are gonna be more difficult. Right? Large tongue, no neck, short neck, fat neck, trauma, list goes on and on, what could be a difficult airway, okay? Has anybody heard of the methods of evaluation? Just to touch on this, because we don't really do this too much in the field unless your PCS reporting system makes you. Does it make you? No. Some of them actually will ask you as to what grade of malapati score they were. Nobody, does anybody do this in the field? No, it's okay. So, mostly ER physicians will do some of this. OR does it real good because why? OR physicians have time, or anesthesiologists have time to do what? They have time to come in and talk to you. They have time to grade and look at how well or how easy of an intubation. So if you've had surgery, that's what the anesthesiologist is doing. He's going to come in and probably ask questions, and he's going to grade you on what difficulty of intubation you're going to be. Okay. The lemon, let's look, evaluate 332 or malapati obstruction neck. Okay. Kind of like the same thing when I talked about it's very difficult to breathe laying flat. Well, lay flat or tuck your chin in and then try to push your mandible out. To do this, it's a little difficult to try to push your mandible out, but if you push your head out like this position and push your mandible out, it's a lot easier. So position the patient as well. 3-3-3, so if you get 3 fingers in, 3 fingers in the jaw, do down this way, and if you can overbite. So if you can stick your mandible out over your front teeth. So that's what that is. Malapati is maybe one you guys might have heard of. So that's basically opening up the mouth and how much of that uvula do you see? And that's how they grade it. 1 is the easiest, 4 is the hardest. Okay. There's other methods out there as well. If anybody heard of the other ones, any other ones you guys use or heard of, maybe taught. No. 4Ds, distension, distortion. So here's tension. Easy intubations are going to be difficult. Very challenging. Why? The 2 on top have had reconstructive surgery. So if you cannot move the mandible out in front of the maximal, then that's a difficult intubation. So obviously these don't. The good thing with these is, at least the one on the right, he's got a big nose. So if you did have to intubate secured airway and he was breathing, you could do what? Nasal. Or look at those nice landmarks down here. So if you absolutely couldn't ventilate this patient and you couldn't intubate this patient, you could do what? Surgical crack. That's right. What about the guy on the bottom? He's got some nice buck teeth there. Is that going to be difficult to intubate? So the larger the buck teeth in the front, the more difficult it's going to be to see and get direct visualization of the cords. Okay? Distortion. So fluid. What I tell you, fluid is one of our biggest options or hindrance in intubation. What's the one on the top left? You might guess that is not the larynx, that is the esophagus. So you want to guess what that is? Esophageal varices.